Good morning, everyone. This is Paula Rofaleski with Leading Age Virginia. I just want to thank y'all for being on this webinar, Managing the Impact of COVID-19 and Therapy's Role. We have with us today Karen Welsh and Melissa Ward with Functional Pathways. And so I will let them introduce themselves and let them go ahead with the webinar. Thank you.
All right, good morning. Thank you so much for having us. My name is Melissa Ward. I'm the Vice President of Clinical and Regulatory Affairs for Functional Pathways, and I am a physical therapist by background, and I'm really appreciative to be here, and I will let Karen go ahead and introduce herself.
Good morning, everyone. I'm Karen Welsh. I'm the Director of Clinical Outcomes for Functional Pathways. I work closely with Melissa. I'm a speech therapist by trade, and really looking forward to chatting with you guys today about our lovely COVID that we've been under for too long now, right? And what we can do to assist facilities in the therapy's role in patient identification and treatment.
All right, so we'll go ahead and get started here. Make sure I got my... So some of the things that we want to talk about today are, again, to start to identify some medical conditions upon admission. You know, for those of you that have had COVID admissions already, or those that have come down with the virus, you may recognize some of the things that we're talking about. If you've not yet had any admissions, or those that have presented with COVID, we're going to talk about some of the presentations that we're seeing with COVID that are unique to COVID versus necessarily maybe other pulmonary conditions, and then how we can kind of stay in front of those conditions. We're also going to, look at some best practices in the industry for, those residents and patients that have COVID versus those that don't. So from a therapy perspective, there's a lot of things that we can do to really assist communities in helping to help these residents recover quicker, stay out of the hospital, as well as what can we do to assist you outside of just those that are recovering from COVID, because we also have a whole other population within the skilled nursing and within the campus that, we have to remember too, they're also under social isolation. They're also under stay-at-home orders, whether or not, they've had the virus, just to keep them safe. And so what can we do to assist the communities in keeping everybody active and engaged? Again, a lot of people have seen COVID admissions, but again, if we haven't, this is really to help us prepare all across, the different disciplines on what we might be seeing. So one of those things, we're seeing a lot of the most, sickest patients coming out of the ICU. They're spending an extended amount of time there, and we're starting to see different conditions emerge specific to COVID. And one of the things that is being reported is a significant amount of delirium. The physicians are seeing a lot of delirium coming out of this population. Some of it's being attributed to the virus itself. The virus creates a significant amount of inflammation, not just in the respiratory system, but they're finding it in the brain. We're starting to see it affect other organs. People are having issues with acute kidney injury. So it is affecting the entire system. And one of the things, again, was seeing it in the brain. Is it the virus? We're also seeing people that are having to be sedated for medically induced comas to be placed on ventilation. They're also sedating people to suppress violent coughing, which can contribute to the cognitive impairment. Some hospitals are starting to run out or have run out of some of those sedatives, and they're having to rely on benzodiazepines, which in the older adult population we know can cause an extended period of delirium. So, these patients are transitioning to post-acute care with some of these residual effects. So you may notice that you're seeing delirium, as they're coming to your building. It is estimated anywhere from 30 to 80% of patients coming from the ICU have a new or worsened cognitive impairment. They're also seeing a new or worsened physical impairment of anywhere from 25 to 80%. Now, some of the statistics, we're just learning from COVID, But what researchers are trying to do is look back to similar patterns when we had the flu, the H1N1, influenza type A, and they're trying to gather information related to that, as well as looking back at some of the countries that were suffering from COVID prior to us. Another thing that they're seeing emerge, again, estimating anywhere from 80 to 57%, which is quite a lot, are having various symptoms of PTSD. So they are seeing post-traumatic stress syndrome coming out of this population. We know that illnesses not only impact the person that goes through the experience, but it impacts the family. And we're seeing to a greater degree how this is impacting the families as well. We're looking at times that we've not been in before. A loved one is ill and the family can't even be at their bedside. So we're seeing a lot of additional stress come out of this. So psychological services, are important, but they're also very important that we be on high alert about the psychological issues and that we're intervening quickly. We know from a rehabilitation perspective, any type of psychological issues can impair the physical rehabilitation process, slows that process down. So the quicker we can recognize physical rehabilitation needs as well as mental well-being, the better off we're going to be at rehabilitating these folks and getting them back to where they were before. Now, when we look at some of the sickest people in the ICU that develop acute respiratory distress syndrome, they also present with additional conditions as well. Anxiety and depression is one of those. Sleep deprivation is something we see. We can start to see bone disease. Excessive thirst, keeping people hydrated is very important, and really kind of knowing that we're expecting that these people can also present with significant thirst. We see an increase in pain. A lot of times they're immobilized in the ICU. We know with COVID patients, sometimes they're spending 10 or plus days in the ICU, and this includes people that are younger than the 65. We're seeing people in their 30s, 40s spending excessive amounts of time in the ICU. The other thing that we know that prolonged ICU stays is a lot of muscle wasting, weakness, and a significant loss in functional mobility. So oftentimes these patients are presenting with significant functional deficits. Sitting on the edge of the bed can be a challenge to them. So kind of preparing for that from a psychological perspective, a medical perspective, and then from a therapy perspective, understanding that from a muscle functional impairment, the therapists are highly trained and really a good resource there to help rehabilitate these patients as quickly and safely as possible. The other thing that we're seeing and need to be aware of is post-intensive care syndrome. This isn't something new. But again, we are seeing it in more mass quantities now during this COVID crisis. And it's made up of a cluster of different health conditions that remain after the person is kind of through that critical crisis. They're outside of the ICU. The issues that we're seeing, again, include their body, their thoughts, their feelings, and again, as I mentioned on the previous slide, how that impacts the family shows up here as well. So we know a lot of times this is really a family condition. It also, we know that this ICU acquired weakness can affect the brain and result in those mental health problems. So let's talk next about ICU acquired weakness. And this is just kind of, we talked about that muscle weakness, muscle wasting. It's a common problem that we see of the critically ill. And from a statistical perspective here on the slide, you see about 33% of all patients that spent time on a ventilator will have post-acute, the ICU acquired weakness. 50% admitted with severe infection, sepsis, 50% of those will develop this acquired weakness. Again, patients that stay more than a week, 50% of those will get that. So if you think about, we're seeing a mix of people on ventilators, and then we're also seeing a lot of people that are in the ICU well beyond the 1 week period. The thing about ICU acquired weakness that is different from generalized weakness that may come out of a 3-4 day hospital stay is this weakness is known to take, it can take over a year to recover and significantly impact activities of daily living, your dressing, bathing, self-care, all of those. It can impact your patient's ability to get in and out of bed, walk to and from the bathroom. It also presents with significant issues with swallowing, being able to time the breathing with the ability to swallow and eat. Oftentimes when a person is presenting with these issues, sometimes breathing and getting oxygen, that's their primary consideration. So nutrition comes after getting oxygen, and so it can significantly impair them. That's why you'll often see physical therapy, occupational therapy, and even speech therapy providing treatment within the ICU is to help as best we can prevent some of these issues, whether it's just range of motion and keeping them flexible and preparing them for the next phase of rehabilitation. So even in the ICU, therapy services are very critical to keeping these people and prepping them. So some of the things that are really important as we prepare to ensure a successful admission and immobilizing all of the staff is having that coordinated approach. I think we did a really good job preparing for PDPM. One of the things that we did as a therapy department with our clients is developing that pre-admission process. And I think this really plays well into preparing for admissions of patients that have COVID. What are their conditions? What are their comorbidities? What services are they going to need so that we can get those arranged and we can get those set up. So as soon as that person arrives at the building, we have that critical team there to get those services mobilized by identifying their deficits, identifying what protocols may apply to that person. Cognitive impairments and psychosocial needs, what are those? Again, psychosocial and psychological needs can impair everything about that treatment from a nursing perspective as well as a therapy. So being able to mobilize those as quick as possible are very important. So about what do we need to do to kind of prepare to get these admissions and make sure that we're successful. The next thing we're going to do is transition into, specifically as a rehab community, what can we do to support the medical interventions and support these residents and their family in ensuring they regain their functional needs and get home as quick as possible, stay out of the hospital, and prevent any long-term disabilities. And for that, I am going to turn that over to my colleague, Karen.
Thanks, Melissa. Yeah, as Melissa alluded to, therapy is an essential role in whether they're in the ICU and especially post-acute across the continuum of care spectrum, whether you're in a SNF, whether you're in assisted living or independent living. COVID has impacted every single person, including ourselves on the phone. It's definitely been a very different approach to living everything. I mean, how do we approach everything? And I think we need to make sure that we're hyper-focused on our residents and our patients because they already have limited abilities to do certain things. So from a therapy perspective, being able to be highly involved on the front end, I think is important to the recovery process and also to preventing additional decline as a result of COVID, whether they had COVID or whether they're just socially isolated. So we've already talked about, CMS has already said that therapy is essential, just like the nursing staff, physician staff, hospital staff. We provide an essential service as well. It's not optional because we need to be able to make sure that our patients recover to the highest level possible. No different than prior to COVID. We were focused on that before, but COVID has certainly given us the heightened sense of being able to do that. They need to be able to receive the interventions that they normally would have received just as a standard of care. Now, obviously, it's a little bit different. We have to have our PPE and all of our standard precautions and increased infection control, but it's still imperative that we're involved in that process. especially for our older adults, because there's a really pretty small window of opportunity to be able to get them to improve before we see significant additional decline. If they lose their strength and flexibility, balance, other functional abilities, it's very difficult to regain those. It takes a lot longer across the spectrum for them to be able to get back to where they were. And a lot of times they don't always achieve that prior level of function. We're just trying to get them to a little bit better level than they were after they had the decline. But the sooner we can identify that, the more independent and the closer to their prior level of function we'll be able to get them. And if they have any new or worsening cognitive deficits, we know cognition is a huge piece of this, especially in relation to social isolation. I don't know about you guys, but for me, being socially isolated, it can really mess with your brain. If you're somebody that's really social and likes to be out and about and around people, it's been very difficult for a lot of people, including our residents, to not have that stimulation, especially if they're not linked up by Facebook or FaceTime or have a cell phone and be able to talk to different people. It's just a totally different environment. So in our senior population and our older adults, we're definitely seeing an impact in that cognitive deficit. They also have, we've noticed that they've lost their ability to, or had a reduced ability to swallow, communicate their needs. It's kind of like a whole new environment that they're having to get used to. And what therapy can do is help them in that process and set up systems and compensatory techniques to be able to do that. So for us, for therapy, and what we've seen across the spectrum is really just us doing the same thing that the nursing staff and the CNAs are doing by following proper precautions, which we were doing all along, but obviously now it's significantly heightened and we have a lot more PPE that we have to don and doff. But making sure that we're aware of the environment, keeping the environment safe, not touching our faces, all of those standard precautions that obviously touching the face was not necessarily as prevalent before, but now I think we're all going to be giving each other warnings if we touch our face. I'm not sure either one of us, Melissa, have touched our face during this presentation, so I think we're good so far.
Yes.
Next slide.
Oh.
Other way.
You can't have a presentation without technical difficulty.
So some of the things that we need to really consider is, and what we should always consider, but certainly now under COVID, is the expectations of the patients and their loved ones. What do they want to be able to achieve for their medical recovery and rehab? That's not a new concept. We can't achieve a goal with a patient to achieve it. If they don't think they can achieve a certain level, we're shooting in the dark. So we've got to be able to involve the patients and their loved ones in that decision-making process when we do talk about goal setting and what they really want to get out of those therapy sessions. We know that there are increased complications and long-term impact on function and quality of life for all of our patients and residents and staff. This is not something that's just localized to our patients and residents and their families. It's us as well as the caregivers. It has not been easy. I know in Functional Pathways, we've had lots and lots of amazing hero stories for healthcare workers, and I know you all have seen them as well and probably have seen them in your own facilities, of going just above and beyond and being totally creative and being able to engage our staff and engage our patients and residents. And that needs to go on beyond COVID, and we need to continue to be able to think outside the box and provide the highest quality of life for our patients, residents, and families. From a regulatory impact, therapy is essential. It didn't change under COVID. We have to be able to provide services that the patients need, so therapy is certainly a part of that. We have to provide all of the services and activities in order to maintain that patient's level. So again, therapy plays a key role in that, just with this, along with nursing, social services, dietary, everybody else that is involved in caring for our patients and allowing them to achieve their highest possible level and stay as safe as possible. Next. Uh-oh, I lost Melissa. There she is. So when we talk about, she talked a little bit earlier about kind of the things that PT, OT, and speech are looking at. And these are not new things either, but certainly it's a heightened state of awareness because we have less eyes on our patients right now. We have less people going into the rooms. The families aren't eyeballing them. They're not out in group activities. So we have to have every single touch that we have with those patients. We have to be heightened awareness and really kind of do almost a head-to-toe assessment of the patient every time we walk into the room to be able to assess that resident and make sure that we're catching any slight decline or change in that resident. So we need to look at therapy being able to identify whether we need to improve mobility and self-care skills. All these things are the things that we can do and are essential. Improving balance and reducing falls. We know that falls under this environment and social isolation have certainly increased during this time. So now is absolutely the time to get your therapy team involved and assessing those residents, the environment that they're in. Preventing hospital readmissions, that hasn't changed either. The measurement for that has not adjusted as far as we know under this COVID isolation. Maintaining and managing those cardiopulmonary conditions, and we're going to talk in a little bit about the program that Functional Pathways has developed called Breathe Study, which is a pulmonary program that we're encouraging and training our staff to be able to do to support the pulmonary conditions. Preventing aspiration, or at least reducing aspiration risk and weight loss. Melissa talked about residents being more concerned about breathing, which obviously is important, but we need to be able to eat as well, and being able to combine those two necessary functions of breathing and eating so that we can reduce that weight loss. Reducing the impact of social isolation. We've noted in a lot of our residents that because of social isolation, we have increased anxiety and increased depression, which can also cause reduction in mobility, reduction in motivation to perform self-care skills, balance, everything else. It causes different fears and different lack of ability to do certain things. We also have the ability to help patients communicate better, communicate their wants and needs, whether that is verbally, whether it's through phone, whether it's through video, whatever that is. We have the ability to help determine and assess the best way for that patient to be able to communicate their wants and needs and be able to do that with staff as readily as possible. And then also reducing care partner burden. This is not a new, definitely not a new concept either. Therapy's whole goal most of the time is to be able to allow that resident and patient to be able to be as independent as possible for as long as possible, which means reduce burden of care for whoever the care partner is, whether it's a CNA, a nurse, a wife, a spouse, a daughter, a niece or nephew, whatever that is, be able to reduce that. And so many more things. We have so many different programs that we can offer from a therapy, not just from, yes, functional pathways, but therapy as a industry. There's so many different things that we can do around environmental modification and energy conservation and swallowing, cognition, everything that we do. This is a very short list of everything that we can enhance in our patients' lives. So we're going to talk a little bit about therapy's role in pulmonary care. Functional Pathways has developed a pulmonary program called Breathe Study, and it is for an interdisciplinary approach to patients' ability to breathe well and be able to continue to perform their activities of daily living and daily tasks as easily as possible with the most amount of breath support and respiratory support as possible. We know under COVID that pulmonary is a focus because of all of the indications that we have of what COVID does to the respiratory system. So now is certainly the prime time to really be discussing pulmonary. It's not a new program within the therapy world, but it's certainly something that will require increased assessment and making sure that we're addressing pulmonary in every patient that comes across our doors, and heightened awareness certainly for our COVID patients. So when we talk about our Breathe Study program, and whoever your therapy provider may be, for Functional Pathways, it's Breathe Study. I would certainly ask about pulmonary programs. Ours is an interprofessional collaboration. It includes nursing, it includes CNAs, it includes respiratory therapy, and obviously PTOT and speech. It is driven by specified protocols, and it really talks about improving the overall well-being and quality of life, because that's what breathing is. We have to have it. It's not like an unnecessary function. You have to do it, and you need to do it as well as possible. So it really does involve quality of life, helping reduce anxiety about shortness of breath and not the feeling like you can't breathe. You know, I don't know about you guys, if you've ever choked or had a hard time catching your breath, it's pretty scary. So imagine living with something like that, like a COPD or a COVID-related pneumonia or something. It definitely affects quality of life. Reducing the risks of any kind of exacerbation around respiratory systems and reducing hospital readmission. And it also addresses the impairments associated with the decreased oxygen levels. So what we talk about, and I've already addressed some of these, but what our Breathe Steady program does is we talk a lot about energy conservation during every activity, whether it's ADLs, communication, swallowing. I think people take for granted sometimes the fact that while I'm sitting here talking, I'm actually breathing as well. But if you have a respiratory issue on top of that, it makes it much more difficult. So for us to be able to get in there and do some basic techniques, some energy conservation, some breathing exercises, and those kind of things can certainly help enhance the residents' ability to perform every task in everything that they do. We talk about airway clearance techniques, breathing exercises such as the huff cough, segmental breathing. Chest PT is involved in this as well. Positioning is huge. I often see residents and patients, and even myself sometimes, I slump down in my chair, and for our residents that have some kind of respiratory condition, posture is a huge component of being able to support that respiratory system and be able to enhance their ability to do certain things. Trach and vent patients and swallowing techniques, being able to make sure for our trach and vent patients that they can communicate, because that certainly impairs their ability to do that in some cases, and also swallowing techniques. Just like with talking, I think we forget that we have to breathe when we eat, and being able to pace those things and sequence those two tasks can be difficult for some patients. Addressing delirium, Melissa talked earlier about delirium, anxiety, and depression through physical movement and through everything that they do, and really kind of talking through those things and some compensatory techniques that they can use to manage that anxiety and depression, and also being able to identify those signs and symptoms of delirium. We've also developed traffic lights for our pulmonary patients and pretty much every clinical category out there. But it gives them kind of a warning sign of, and I think we actually show one in the next couple slides, so I'll hold that traffic light conversation for just a second. But also being able to address strength, balance, and ADLs and mobility. Not anything different than what we do normally from a therapy perspective, but adding that pulmonary component on top of it. So one of the things that we did for our staff and clients was to develop a lot of resources to support not only the role of rehab, but the role of every staff member and family member in the facility and residents to be able to talk through this, what do we do during a pandemic, and be able to provide support to our therapy teams and our clients for ideas of how to maximize the benefit that we can provide to those patients, and kind of out of the box thinking of, because it's a new day. I don't think we'll ever go back to our old normal. It's going to be a new normal, and we don't know what that's going to look like yet. We don't know if we're going to have to wear masks all the time in nursing homes now. We don't know what that process is going to look like. So being able to provide up-to-date, up-to-the-minute information to our staff has been important for us. So we developed the Role of Rehab Providing Care During a Pandemic resource, which really talks about just how do we deal with this everyday change in our normal. So some of the other resources that we've created, next slide, Melissa. Just a little glimpse into kind of a couple of things that we've done. We have a breathing rainbow arc, which is something anybody can use, and I think we're going to provide this for you guys as a resource. And you can use this with anybody. It doesn't need to be specific to your COVID patients, and it doesn't even have to be somebody that has a pulmonary issue. It can be anybody, because we all have to be able to breathe efficiently. So the breathing rainbow arc is kind of cool. You print it off and you trace the rainbow with your finger, and you breathe in on the way up, and then you breathe out on the way down, and you sequentially move up the rainbow. It's just a simple little breathing exercise. If you don't have incentive spirometers or you don't have other tools, it's a very simple visual that most patients are able to do just to keep them breathing and focusing on that breath. We also have our clinical pathways. We have our pulmonary pathway, which we show you a little bit here. Lots of people have different versions of clinical pathways. I know nursing has had clinical pathways for years and years, but we've developed ours for PT/OT and speech, just to kind of give a guide of everything that we need to make sure that we're doing with that patient in time frames, so that we're as efficient, as effective as possible throughout that patient's stay, and that we're addressing all of the needs of that patient. Next. So here's our pretty little traffic light. We have one of these for, I think it's about 40 now, conditions, pulmonary COPD being one of those, respiratory distress. And what it does is it gives the patient a visual of, okay, here's where I know I'm in the green and I don't need to worry. If I'm in the yellow, I need to probably call my doctor, or I need to call my caregiver or my nurse and let them know that this is happening. And red means this is not good. I gotta do my next steps. I gotta go to the hospital, or I gotta talk to the doctor. So it's also a good tool we found with our staff as well, for the CNAs, for the nursing staff, activities, dietary. Some of our clients have used these for the entire facilities to be able to do kind of a quick head to toe for the residents that have these different conditions, to be able to identify when it's time to bring somebody else in or do something different. So we're going to talk real quickly about rehab's role beyond COVID-19. Certainly currently during COVID, but then other things, and it's not a ton different, but under COVID, it's definitely different because we're dealing with social isolation. So from a PT, OT, and speech perspective, for us, it's just really a heightened awareness of when a patient has a decline and when they're at risk for decline, and being able to identify those things in the patient that are changing, even if it's just a nominal change. I've always said, and for years and years, anytime I have, and housekeepers are the ones I usually use as an example, anytime I have a housekeeper come up and they say, you know, Mrs. Smith just isn't quite right today. I personally think isn't quite right should be its own ICD-10 code, because it usually leads to something else, and it usually does have some kind of implication, because those housekeepers and CNAs and dietary are in those rooms more than we think, and they have a different kind of level of engagement with those residents. So being able to identify those and bring those staff members into the fold to say, hey, have you noticed anything different? And please let us know ASAP, because we have such a small window of time to identify that deficit before it gets really, really bad. So we'll talk a little bit about each discipline, and then we'll wrap up and do some Q&A if you guys have any questions or anything. So from an occupational therapy perspective, under COVID, certainly it's about environmental modification, because we're not out and about. We have residents that are staying in their rooms or staying in their apartments that can't get out and about. So making sure that their environment, in that confined environment, is as safe as it possibly can be, whether it's by using visual cues or reducing shadows, glare, arranging furniture differently, going through their day a little bit differently, putting things where they can see them, find them, from a cognition perspective as well, just being able to make sure that that environment is as safe as possible. Also looking at weight loss. I know in a lot of our SNFs, if they are using the disposable containers, like the to-go containers, a lot of times those are white. Well, if you have mashed potatoes or macaroni or anything that does not contrast with that container, if you have someone that has a cognitive deficit, any kind of dementia or visual deficit, they may not necessarily be able to identify that there's even anything in that partition of that container. So being able to identify those deficits or potential risks and being able to educate the staff on how we can adjust those kinds of things to be able to make sure that the patient can optimize their self-feeding. Low vision, I kind of alluded to that a little bit as well, making sure that we're looking at that low vision, we're doing color contrast, we're looking at depth perception, we're reducing those falls by looking at the environment for those residents that have low vision and making sure that we're setting things up appropriately so that we can reduce their risk of any kind of injury and also increase their risk for being able to communicate appropriately and read things and get materials, etc. Leisure pursuit. OT is not just about ADLs, it's also about what do I like to do? As a resident, what do I like to do? What are my favorite activities? It's not about just dressing and bathing. It could be about sewing. Maybe I like to sew and I can't hold the needle very well anymore. And that's one thing that provides me with stress relief, and now I can't do it anymore because I'm starting to decline. OT can come in and look at those things, work on fine motor, work on sequencing, all those kind of things to be able to adapt that patient's environment and also to strengthen that patient to be able to do whatever it is that they like to do. For PT, Melissa, you want to talk about PT or you want me to take a shot? I hate to step on a PT's toes.
Let's see what you got, Karen.
Oh, okay, good. I think it should be an honorary, you know.
Oh, yeah, I don't mind taking this. So yeah, again, I think we think a lot of the traditional things with physical therapy, and as we're talking about the state we're in, we really have had to be creative. We're working now in confined spaces. So as a physical therapist, what am I doing within this confined space? And so really I want to look at optimizing the patient's environment. How can I keep them as physically active? People that are on social isolation or they're isolated to their room, they're less mobile, they're not walking to the dining room, they're not going to activities, so they've become a little bit more sedentary. And when you become more sedentary, we start to see a lot of issues there. And so one of the things is optimizing the mobility in the confined space. Perhaps this resident, was mobile before. I need to look at their confined space and where can I maybe make some more? Maybe they didn't, necessarily need to get on the other side of their bed very often, but if I move that around, they want to sit by the window. I can work with them on stepping sideways within their walker to make sure that they're safe. So really looking at the setup of their room, and interactive exercises to promote flexibility and balance. And, we talked a lot about delirium and depression, and both of those have been shown to be impacted by exercise. And so physical therapy can do structured exercise. But one of the things that we really need to do in this, partnering is transitioning that movement, not just from a physical therapy perspective, but working with the entire team. And it doesn't have to be structured exercise. When a CNA comes in to maybe do some things in the room, it's just getting that person to move. And it could be just moving, arms and legs to a commercial. Just having them get that movement can help decrease delirium as well as decrease depression as well. Also thinking about people being more sedentary, we see a lot of pain in our population. We see arthritis, different joint disorders. Being sedentary is going to a lot of times enhance that because arthritis is helped with movement. You're a little stiff in the morning, but you move around. So you're going to start to see some different pain. One of the things Karen mentioned was everybody needs to be eyes and ears. Keep an eye out for increase in requests for pain medicine, reports of increased difficulty with maybe self-care, moving a joint. Is the patient, and resident grimacing more? There's a lot of things therapy can do holistically from a non-pharmacological perspective to help with pain, whether it's some sort of physical agent modality with heat, electricity. It could be some manual therapy with some massage there. There's a lot of things that therapists have in our toolbox that are holistic versus pharmacological. Reading in the industry, there's a real big push for physical and occupational therapy with the opioid crisis. And so maybe these aren't some opioids, but anything we can do to provide a holistic pain approach, to these residents as well. And again, it may be setting up programs for everyone to help carry out to keep those joints mobile. The other thing is fall risks do not go away. And in an era of conservation of PPE, every time somebody gets up, we don't necessarily want to gown up and run in if that person is okay. So an idea that one of our managers brought to this, which we thought was a great idea. Now, this was before COVID, but it definitely translates. And one of those is kind of taping the walker. So what they did at this building was, if someone was cleared by therapy or nursing to walk around their room, they had green tape on their walker. If they required someone to be in there with them, it was yellow. And in this scenario, if someone had red, it was a weight-bearing precaution. And so what we've done is we've seen people adapt this green, yellow, red to the isolation in their room. If somebody is up with a green walker, even whether I know them or not, I know that they've been cleared to be up. So I don't have to concern myself with PPE going in that room to check on that resident. I know they're good. If they're yellow, that may be somebody that I need to say, maybe in your building, yellow might mean they need somebody in there, so we would get someone in there. And then red would be they absolutely cannot be up. Walker needs to be in another room out of sight. So that's just something to be thinking about, of a creative way to have a quick glance as to how that person is functioning to reduce that in and out of the room. Another way to minimize risk of falls is to, with your therapy department, once we identify the optimal height of the bed that works best for their joint mechanics, is to put a piece of tape to maybe where the bottom of that bed should be the height. So when someone goes in, if it's not even with that tape, it could be too low, which can be problematic for someone that has joint difficulty. If it's too high, it could be problematic as well. So that gives you a difference. Another technique that we use in therapy is, we have our procedural memory. So if you think about walking, it's something that we've done getting dressed every day. We don't really have to think about it. It's so well ingrained in our mind. If I sleep on the right side of the bed, I'm used to getting out on the right side. Well, one of the things we can do to challenge residents into working their core and challenging their memory and falls is to take them and put them in a new situation. So I'm going to practice their bed mobility on the other side of the bed that they're not used to. So they don't have that same that procedural memory that it's kind of written in there. They're really having to problem solve and think step by step. So it helps challenge them cognitively, it helps challenge them physically, and it's also going to make them safer if for some reason that side of the bed is blocked that they're used to, and they go to try to get up on the other side of the bed. I've already been working on giving them some of those new memories there. So those are just a quick sneak into some of the things that we can help do from a physical therapy perspective. And then I think, Karen, this is probably going to be you.
I think I can field this one. So speech therapy, I've been a speech therapist for over 30 years, which is almost hard to say out loud. It makes me feel kind of old, but maybe I started when I was 1. But, I think one thing that people do not know about speech therapy is that we really are trained to have a holistic understanding of the brain and how it functions. We learn everything there is to know about neuroanatomy and how it affects every single thing that the patient does. So our role is not only just from everybody thinks, oh, well, I can talk just fine. Well, it's not just about talking. It's about the language. It's about processing, sequencing, executive function, higher level tasks, helping with PT and OT to determine how that patient needs to sequence and process information. So it's not just about talking. It's about understanding what's said. It's about communicating. Swallowing is a huge piece of what we do. Cognition, memory, dementia management, communication strategies around patients that have dementia. We have a Pathways to Engagement program at Functional Pathways that involves TIFA, SNOS, GEMS, staging. If you have not staged your patients, I highly recommend that you do that and come up with some kind of, whether it's a green, yellow, red, or you do the TIPA snow gems, that you can indicate to your staff what that patient needs from a communication perspective, what you can and can't do with that resident, to be able to communicate effectively, and also for the staff to understand how that patient's going to communicate with you. So speech really can be involved in everything with that resident, because everything that we do involves the brain, all of the brain. So we are adept and skilled at being able to establish different treatment protocols around that for speech, making the patient able to communicate their needs, language to be able to effectively communicate. It's not just about speech, would be, can I understand what they're saying? Maybe their speech is slurred or they can't get their words out right. Language, ability to communicate as well, and understand. Comprehension is huge. And I think that's why staging of your patients, whether you use the global deterioration scale, or I hate to say the BIMS just because the BIMS is such a primitive tool, but whether you use the slums, use your therapy staff, especially OT and speech, to help stage those patients so that you can be able to better address those patients' needs and communication abilities. Swallowing, like I said, is huge. Being able to safely intake their food and drink and medications. Don't forget about that piece. Medications are huge. And being able to assess that and how they need to be able to swallow safely. Sequencing is a big piece of everything that we do. Not just for, not just sequencing how I'm going to turn on my computer. How am I sequencing my ambulation? How am I sequencing my ADLs? How do I do everything in the best way possible, in the safest way possible? Memory is a big piece. Again, I know I've said it 2 or 3 times, staging your residents is huge in being able to determine what tools are going to work best for that resident based on where they are on that stage. Problem solving, big thing for safety, and kind of goes hand in hand for me with safety awareness, but really speech can be involved in everything that that patient does. And being able to identify when you have a change in those levels. That's why I think staging is so important, because you should then be able to see what the difference is and be able to educate the staff, and speech can certainly be heavily involved in that education of how to communicate, how to get that patient to do the things that they need to do, and what that needs to look like to be able to stimulate that brain. And certainly under COVID and isolation, the brain is like a muscle. If you don't exercise it, you're going to lose ability. You're going to lose memory. You're going to lose cognitive function. It has to be stimulated in order to stay active. So anytime you go into that room, if there's something you can do, ask questions. Ask them about their grandkids. Ask them to tell you about something they did when they were in high school. Try to stimulate those conversations and not just be in the room giving the meds and walking back out, but just helping to stimulate that conversation just to keep their brain active. We developed, and I think we're going to share it next week, probably, Melissa, but the cognitive calisthenics that we developed that just gives some little tips and tools and kind of little thoughts about how to keep that brain stimulated on your patients when you walk into the room. Or even when you're not there, just different things and activities that you can give the residents to do that will keep them cognitively stimulated. So speech is certainly able to be involved in all facets of care, and should be more than willing to do so. I know I love it, and I know our staff has been very excited to be involved in the holistic treatment of the patient. But from an OT, PT, and speech perspective, reach out to your therapy teams, ask them what they can bring to the table if they're not already, and let them help you think outside the box. That's what we do all day, every day, is take situations and look at situations and figure out how we can adapt them as safely as possible. So bring your therapy team into that fold and really help them, let them help you be successful under this social isolation and help reduce the risk of patient decline and allow patients to be as safe as possible. So with that, I'll turn it back over to Melissa to close.
Great. Thank you, Karen, so much. And again, thank you all for attending. Today, we just wanted to give kind of a general overview of some of the differences that we're seeing in this population and then how therapy can help. And again, not just from a COVID perspective, but general overall. We do have a second presentation next week where we're going to spend more time diving into thinking about social isolation and what are ways that, we've seen so many creative things going on. We've learned from our therapists, from our communities, things that we've seen. And it's really just an opportunity for us to get together and share additional ideas and things that we've seen to keep not only the residents engaged, but keep all the employees engaged and keep the families engaged. A lot of the activities that we're talking about and seeing really cross over, not just skilled nursing, assisted living. They can be taken back to people's families who have kind of been on lockdown as well, and just really kind of sharing in some of that joy that we're still seeing, kind of that happy feel-good stuff. So join us next week. We're going to have a lot more discussion about specific ideas, and we really enjoy, the sharing back on what you guys are seeing, what's bringing joy to your community. And I think, what we've seen is that from the employee's perspective, I know that I can speak from our therapist perspective, when they can bring joy to the residents, it pays them back in multiples. And so I think that's been really the fun thing, to really be able to see the sunshine and the smiles on the faces with some of these things. So looking forward to that. Our numbers, our email addresses are here. If you have any questions, if there's anything that we can talk through, we're always happy to do that. So again, thank you all so much for the invitation today, and hope you can join us next week. So Paula, I will turn it back over to you.
Thank you, Melissa and Karen. That was absolutely wonderful. I learned so much, and I hope everybody else did too. I don't see any questions. I told them they can unmute themselves if they wanted to ask questions as well. I do want to just reinforce that next week's seminar is going to be on Thursday, the 14th at 2 p.m. And that should be very good, since this one was a great webinar. So thank you again, Karen and Melissa, and to Functional Pathways.
Thank you. Have a great rest of the day.
Thank
you.